Okay, welcome. Greetings from Fauji Foundation Hospital, Rawalpindi. Um, we had a 76-year-old lady who was diabetic hypertensive. She had entered MI in 2020. She had double disease with a, it wasn't occluded, but it's like 99% osteostenosis. And she was offered bypass, but the surgeon turned it down because of frailty. We have a lot of frail people there. So this time she then got readmitted with Donstemi and she had EF of 35%. And because of recurring chest pain, we decided to study her. And there's a question of like overthinking your procedure. So we thought, look, the RCA was kind of moderate, so we'll just take right shots and then take a left guider and save equipment and do a procedure. So when we took the right shots, we found that the LED was cross-filling. I hope you can appreciate the cross-filling. So that kind of changed stuff for us. And so when it was cross-filling, we thought, look, there's so much cross-filling that we would need a double injection. So because she was being heparinized, we then did a femoral stick with a 5 French. We always do these with the ultrasound guidance. And it's very small femoral. So we thought we'd not be able to get a 6 French in. It would be uncomfortable. So we put a 5 French in because we thought we'd just be able to use it as a contralateral injection. So so that's what the total thing is all about. The circ has a moderate lesion. It's critical. Initially written as moderate, but it wasn't. The LED is almost shaved off. The RCA has got some mild lesion and it's cross-filling the LED, and there's a total occlusion in the middle. But there seems to be some sort of a trickle antegrade also. So that's the summary of the case, that the moderate dominant RCA, there's a large non-dominant circumflex, and there's an osteal LED lesion which is cross-filling. So what we thought was that we'd use a double stick, and we used a micro, and on the left side you can see how advantageous it is to use a contralateral injection, and how precise it is in directing your wire to the right place. After we got it down, we then dilated and we found that the LED was filling, and it's a very small caliber. It is, just less than, there's the right. So what we did then was that we switched the catheter. We tried to get the right out, and there was some spasm. So we thought that, we just continue working with the left coronary artery with the, so we switched the left system, the right, 5 French right from the femoral approach, and we switched to the 6 French on the real side because there was spasm. So initially we thought we'd use a 7 French and make it easy for us, but there was a problem with the spasm, so we just took a French, the 6 French from the right. And we still thought that we may be able to get on with a very simple system. And what we did was that we fixed the circumflex first, and we thought we'd spare the ostium, and maybe we'd try and plant an osteal stent in the LED also. And so when we placed a stent there, we found that there's going to be a lot of plaque shift, and so clearly it wasn't going to be easy to place 2 osteal stent in this kind of lesion. So at that point we decided that we need to switch to a 2 stent strategy. And because of the spasms and all, we could not shift to a large catheter. So what we did was that we switched the right guider, the right catheter with a guider, and we used the 2 stent strategy for the left system. So the initial XV3 has the wire going down in both the circumflex and LED, and the other catheter, which is another XP, we used that to wire the circumflex. And then we took that circumflex wire out, and so we had one wire from one guider going to the circumflex, other wire going into the LED. And you can see from the left screen that how the wire is being introduced from the other catheter. And in the right screen, you can see how the stent is being advanced into the LED, and there is a crushing balloon parked in the circumflex. So using these two guiders for bifurcation is actually known as a ping pong technique. So now we're trying to place the stent properly, and after we've inflated it, we pulled back the crushing balloon. Some people keep the crushing balloon there, but when you know you can pull it back, we pull it back, and it was like a 3-5, and we inflated, and we always give this little antigrade trickle to see what kind of flow is going down. So with this, you can realize that 3-5 would probably not be enough. So we crushed that, and then we recrossed the, we did a pot there, as you can see on the first screen. Let me go back, it's not playing. After I go back, it'll play again. So the one is black should play. So, yeah, no, it won't. So we crushed that. I think the first few it did play. I can go back a little once more. And now we can. Yeah, so we did a pot in the first one, and then we recrossed, and then we inflated there in the across that, and then we did a first kiss. So we thought we were doing incidentally we're doing a crush here, but the LED is such a small vessel that we, instead of crushing the circumflex, we thought that the circumflex and left main stem would be able to take one stent. The LED was such a small caliber that to put a stent from LED small caliber to a huge austere left main would be so tricky. So we decided to crush the LED stent rather than the circumflex, which is usually done in DK crush. So whether it's reverse DK crush, I'm not sure. So we crushed that, and then we put a stent from left main into circumflex. You can see in the left one that we're placing a stent there. It's a 3-5-18, and we're giving some injections just to show that we always do this to make sure that our stent is placed properly. The ostium seems to be covered well. And after that, we did again a pot. You can see that in second frame, and then we did a kiss. You can see it in third frame, and then did a final pot. And so this is the final result. And after we finished the result, we were admiring the result, and we saw something filling deep down. There's something filling in the circumflex. Yeah, if you look at the circumflex, the second view, there's some dye filling there. And we said, oh my God, that's like a perforation. Let me go back again and look at the circumflex in the second view. Okay, so what we did was that the patient was quite asymptomatic at this point, despite this perforation. So we finished off with the DK crush, or the reverse DK crush, and let me go back a little so that it plays for us. Yeah, that's one second. And so look at the second view with the echo probe. We looked at, the patient was quite stable. There was no drop in blood pressure, no change in heart rate. Everything was hunky-dory, and we noticed perforation. So we did an echocardiogram, and there was no pericardial effusion. So we're wondering what's happening here. So we injected and took an echo, and we found that the dye was emptying into the left ventricle. So it was we thought it's a perforation into the LV, so it's quite asymptomatic. But then we went back and decided to see where exactly did we create this perforation, and we looked hard. And if you can see these images and look at the circs, and you find that in the circumflex, there is always a dye hair and a hair right from the start. So this is probably not a perforation done by us, but because the vessel was occluded, it wasn't filling well. So after we opened it up, the flow got better. So it's actually a cameral fistula, which is a coronary draining into a chamber. So that's what it eventually turned out to be, and saved us the embarrassment of having a perforation in such a complex case. So that's the end of our case.